Okay, so we are joined today with Dr. Nicholas Tompkins, who is a palliative care physician practicing in Ottawa with RPCT, the Regional Palliative Consultation Team, and the Palliative Care Unit in Ottawa. All right, so I'll turn the podium, the virtual podium here over to you, Nicholas. Thanks so much for being here.
Perfect. Thank you so much, Carl. I appreciate it. And thank you everyone for joining. We'll get into our topic today. So pain beyond the basics. Hopefully it'll be a fun session. It'll keep you entertained and interested for the next 2 hours. Yeah, so a lot of you, I think are probably pretty familiar with things like learning essential approaches to palliative care, the LEAP training courses. So really the focus of this talk today is to kind of go, what are the next steps beyond the kind of conventional things we do for pain? And we'll kind of get through that. So thank you so much. And yeah, let's begin. So first off, oh, there we go. Just wanted to start with a land acknowledgement. Just wanted to acknowledge that we're here on the traditional unceded territory of the Algonquin Anishinaabe Nation. For countless generations, the Algonquin people have lived, cared for, and gathered on this land. We honor their enduring presence, their stewardship, and their ongoing contributions to our community. We are grateful to live and work on this territory and commit to continued learning, respect, and reconciliation. So just a few housekeeping things first before we get started and get into the meat of the presentation. So this is just a disclosure that comes from the Scientific Planning Committee. So these are people that are all with the Champlain Hospice and Palliative Care Program. As far as any disclosure or kind of conflicts of interest that I have, so as far as any financial interest, I do have some grant and research funding support that comes through the Briere Health academic organization, incentive and innovation grant funding for research in palliative care, particularly not really related to a lot of the things that we're going to be discussing today, but more so physician and prescribing practices in long-term care homes in Ontario. I'm also a LEAP facilitator as well, and as previously disclosed, I'm one of the physicians that's worked with the Regional Palliative Consultation team here in the Champlain region. So I've got no kind of disclosures of financial support to disclose. There's no for-profit anything that's going on with any of this. And yes, and I was able to provide the slide deck to the Scientific Planning Committee beforehand to mitigate any potential conflicts of interest. So to begin, just wanted to start with a pretty strong and profound quote. It comes from Dr. Balfour Mount, who unfortunately just recently passed away a few months ago now. So when pain and other symptoms are controlled, there really is limitless potential for quality of life at the end of life. So it's a pretty strong statement. And hopefully throughout the course of this presentation, with being familiar with kind of new modalities or kind of next steps in taking care of pain, we'll be able to address patients' suffering better so that they can have a better quality of life towards their end of life. Can everybody hear me okay? I just saw that in the chat. Okay. All right. So what we'll be focusing on today. So first and foremost, I had a lot of interest from a lot of people I kind of polled before making this presentation. Beyond the basics, pain, you can do a lot of stuff. So things that people are very interested in are CADD pumps, or continuous subcutaneous infusion pumps. We're going to talk today about methadone, so pretty interesting medication. We'll kind of dispel some myths and hopefully get people more comfortable with its use, particularly in palliative care. We'll talk about the fun drug, that's a pun, ketamine as an analgesic as well. And then also we'll talk and chat about a couple procedural interventions that people can use to help with pain. So first, to start off, continuous subcutaneous infusion pumps. So when the pain won't quit, let the pump do the heavy lifting. So I'm going to start with a Zoom poll. This is kind of our first question. So when should we consider transitioning a palliative care patient to a pump? So options we have here are pain is persistent and requires frequent subcutaneous injections, 3 to 4 a day. Oral route is no longer reliable due to nausea, vomiting, dysphagia, or declining intake. Pain control is fluctuating with peaks and troughs between doses, or the patient is transitioning to end-of-life care and comfort is the main priority. And then, Carl, I think you have the control of the poll there.
Yeah, I'll just give it a few moments here. I see we have about half people who have answered so far.
Perfect. Okay, so it looks like from the majority of answers that we have here, so really there's no right answer for this. It just kind of get to spark people's kind of thoughts about what they think may potentially be the potential options there. So majority of people kind of said when pain is persistent and requires frequent subcut injections. So yeah, so it's good. So it's good. People are pretty good options there. So I always like to frame things in a case to really solidify the knowledge and the learning that we'll be getting. So I'll present this first initial case of Mrs. LM, who's a 68-year-old with metastatic pancreatic cancer living at home. So this is someone that's having worsening abdominal pain and back pain despite escalating oral opioids. Currently they're on about 8 milligrams PO every 4 hours scheduled with 5 milligram Q4-hour PRN. They haven't taken any extra doses or PRN breakthroughs in the last 24 hours. Their oral intake, however, due to the progression of the disease, has been declining because they're just getting more and more nauseous and more fatigued. And now they're getting to the point where they're unreliably able to swallow the medications. So on exam, they're fatigued, intermittently grimacing, mild abdominal tenderness, no new focal neurological findings. And really what we're seeing is there's uncontrolled cancer-related pain, refractory to oral opioids, and limited by poor oral tolerance. So it's pretty tough to get on top of someone's pain if they're not able to swallow the pills that are going to make it better. So we've been talking about the CADD pump. So I only just realized recently that this is actually a brand name. I'm not allowed to say CADD, I guess. Sorry about that. But so CADD is actually a brand name from the particular company. That being said, this is all kind of geared, so continuous ambulatory delivery device, or what we also know as a continuous subcutaneous infusion pump in most cases. There's a picture of it here on the left, as you guys can all see. So they're a small portable infusion device that delivers continuous infusion of one, or in some cases more, medications for symptom control when oral route's no longer feasible. So it's used pretty extensively in palliative care and end-of-life care for continuous symptom management and occasionally for patient-controlled boluses as well. So the focuses that I've kind of had for this are more so kind of in the community setting. So a lot of times, depending on your practice and where you are, more often you'll probably see CADD pumps in the community. You also see them in the hospital, depending on who's trained, and we'll kind of get into that. But yeah, just kind of keeping that in mind. So why are CADD pumps good, or pumps? So they can deliver smooth, continuous delivery of opioids and other meds. So you get the fewer peaks and valleys, right? So if you kind of think of it, if you have someone that's on intermittent subcutaneous injections at home, they're getting, a dose, things are kind of picking up, they're wearing off. They get another dose 4 hours later, goes up, wears off. So the nice thing with the continuous infusion is that you have continuous, nice, good pain control where people are able to kind of get things better under control. So you can easily, rapidly titrate it. So all you got to do is just press a couple buttons. They're right there on the pump. You can increase the dose, you can decrease the dose, and kind of titrate to effect. You can really facilitate putting in very complex regimens for things like, say, hydromorphone and midazolam too, in some cases as well. Makes it much easier than trying to manage intermittent injections, like I previously said. So they're great for patients with poor PO tolerance. So people or patients that have nausea, dysphagia, obstruction, cachexia, are patients that have, GI cancers that have question of, are they really absorbing the medication that they're taking orally? CADD pumps work really well there because we know if we're putting it subcutaneously, it's going to be absorbed than what it is in the gut if they have any kind of impairment. Another huge advantage is that people can stay at home with reliable symptom management. So the pumps are portable, they're battery powered, people can shower with them, they can still walk around. You can usually see patients that kind of put them in a little fanny pack. So it's pretty handy in that sense, keeping people ambulatory. It also allows for patient-controlled boluses. A lot of the data shows that when people have control over their pain, they actually have better outcomes in regards to their pain management, their overall sense of quality of life, and their ability to maintain their function. Also reduces caregiver stress. As you can imagine, if somebody's at home, you're going in, you're giving them, all these syringes that are pre-drawn because their pain management or their schedule is basically you got to take hydromorphone 1 milligram, you got to do an injection every 4 hours in the middle of the night. That's a lot to ask of a family member. Unfortunately, I wish I could wave a magic wand and get 24-hour nursing care for every single person at home. Fortunately, it's not the case. So a lot of that has to go into the family, and CADD pumps are good to be able to kind of mitigate that stress that goes to the family. And it can also support non-opioid medications too. So things like ketamine, which we'll talk later on in a chat in our presentation today. You can also use other things like anxiolytics, like midazolam, like I previously mentioned. Why isn't CADD pumps great? So really the big burden would be kind of cost and resource use. So the devices, the tubing and batteries are more expensive than kind of our standard oral or subcutaneous injections that we give intermittently, particularly in home care settings. I also need extensive training for it. So particularly with either nursing patients or families, not all caregivers feel comfortable troubleshooting, say if the alarm goes off. Mechanical failures are pretty rare, but it can happen. So things like occlusions, kinks, low battery, particularly if you're thinking of someone that's getting an infusion in the home setting, if there's not a nurse that's readily available, that can be sometimes very distressing to family members because they have to wait until someone can show up to troubleshoot it or fix it. Also, can have a psychological impact on patients, particularly. Some people find that pumps are stigmatizing and quite burdensome. Makes people kind of feel sometimes more sick than what they are, or kind of quote unquote sick, just because they're kind of tethered to something, right? So we'll always have to be kind of mindful of that. And, not all medications are stable enough or appropriate to be able to use as a subcutaneous infusion. So when should we consider a pump? So if someone's having moderate to severe pain and a non-opioid naive patient, when can't take anything by mouth, or they're having difficulty with taking things by mouth, if they're taking too many pills, it's not uncommon, especially as people's tolerance builds up over time for their pain. They're using more and more opioids. It's tough to be able, sometimes people are almost getting buried in the amount of pills that they have to take, right? And so they're taking 5 or 6 or 7 or 8 sometimes pills at a time. And that's a lot, especially if you're getting more frail and weak. That's a big burden. And then also unpredictable and escalating pain pattern. The nice thing with the subcutaneous infusion for the pump is you hit the button, 2 minutes later, there's going to be an effect, as opposed to I take a pill, 30 minutes later, there's going to be an effect. So what I'm going to go over next is something that had been kind of requested from a few people, particularly in the community. So this is all kind of pertains to more so how to be able to order a pump. particularly in the community. So for those of us who are prescribers, so either nurse practitioners or physicians that are in the community, I tried to really make it simple to be able to figure out how to do this. So so working on the regional palliative consultation teams, I get lots of calls on, this is very confusing. It's an infusion. Like, what do I do? There's concentration, all this stuff. So basically, this is the regional palliative consultation teams, like 4-step guide on how to be able to easily order a CADD pump in the community. So the first thing that you have to do is make sure that there's a referral for home care with Ontario Health at Home. So there on the screen, you can see that there's the form. Pretty easy. All you have to do is just really put in home care referral, Ontario Health at Home. This is the first PDF that kind of pops up. So the big thing, really, all you have to do is just fill out the demographic information that's kind of on the top. But encircled in red there, just make sure somewhere, whether in relevant diagnosis for referral or reason for referral, just put palliative nursing in caseload, or just that this patient should be on a palliative caseload. In doing that, then Ontario Health at Home will have palliative nursing that will be set up in the home, and then they'll be able to kind of accommodate getting all these things set up to set up a pump. All right, step 2. So the actual order for the CADD pump. So using the pain and symptom management form to order the pump. So again, right here on the right, it's actually pretty simple. It's not as scary as it looks. Again, you just fill out the kind of the demographic information on the top, and we'll kind of walk through what you have to do to be able to order it. To be able to find the form, all you have to do is just put pain and symptom infusion or pain and symptom, and then in the Champlain region, you just type in Champlain 2, or you can just put Ontario Health at Home, and it'll be the first PDF that pops up again. So basically, the big things we have to do, same with any other kind of order you'll ever have to make. You need the drug, the route, which is more often than not subcut, unless the patient already has an existing PICC line. Then you can kind of use that as well. What the continuous rate's going to be, what the patient-controlled analgesia, or kind of similar to kind of your PRN dosing will be, what you want to lock out the pump at for max limits, and then how much reservoir or how much actual medication that you want to give the patient. So the lockouts are important because basically that's kind of our fail-safe button. So if you think of it, if the patient has the ability to hit that button, we don't want them hitting it all the time, and it's going to be giving them medication the whole time. What we can do is we can actually lock it out to say, we can only give 1 dose every 1 hour, or we can do it every 2 hours, whatever you really kind of want, just to make sure that it's safe for the patient. So I can't emphasize this enough. Pumps should not be started on opioid naive patients. So if you're ever going to be starting a continuous infusion of opioid on a patient that's having pain, I would hope to expect, make sure that they were previously on opioids before, because in most cases, like, you can't go low enough at a continuous infusion to basically, it'd be too much. So make sure that they've been on opioid before. So the way to kind of figure out what your basal rate is going to be, so this kind of goes back to LEAP teaching that I'll kind of rely on in this case. So all you have to do is just calculate what your total daily dose is of your opioid. And we'll go through an example. And then you just divide it hourly, and then boom, that's what your basal rate is going to be. So that's what the continuous infusion per hour will be. For the PCA, or which would be equivalent to kind of what your PRN would be, you just give 10% of the total daily dose, and then you can just put it as every 1 hour. So as an example, so say if someone was on long-acting morphine at 50 milligrams twice a day, and they had a morphine 10 milligrams PO Q4 hours as needed, they're using them 2 times a day. So if you did the math on that, you can trust me. If anyone wants to check the math, they can go ahead, but just trust me. So their total daily dose would be 120 milligrams of morphine PO. So remember, if ever you're going from PO to a subcut route, that's twice as strong. So you want to make sure that you divide that in half. So that would be 60 milligrams subcut for a total daily dose. Then basically just divide that by 24, and that gives you your basal rate of 2.5 milligrams per hour. So then basically, if we know that the 60 milligrams of subcut is our total daily dose, 10% of that is 6 milligrams, and then we give that Q1 hour PRN. That's it. So pretty easy, not too hard. But then how do we figure out the concentration? So unfortunately on the form, you actually have to indicate how much concentration or what concentration of medication that you want to actually put in the cassette for the pump is. So on the form, on the second part of the form, when you look it up, it actually has this handy little table. So you can ignore pretty much everything that's on that second page, except for this part. So here, this is the only thing you have to worry about. So there, all you have to know is what your expected subcutaneous total daily dose is going to be, and that'll give you what the suggested concentration should be. So in our instance, because we know that the total daily dose is 60 milligrams, we would want to order a 5 milligram per ml concentration. And then that's what you put on the form. And that's it. Pretty easy. So next step for number 3, fax the prescription into Ontario Health at Home. On the top of the form, there's the fax number. Make sure you're sending it to Ontario Health at Home and not to like the patient's pharmacy or anything like that, because they're probably not going to have the medications. The nice thing is if you send it into Ontario Health at Home, they're going to figure it out for you. So they're going to be able to ensure that the supplies are delivered. Nursing visit's going to be coordinated with it to set it up. They're also going to they'll send the prescription along to the pharmacy with you. So in the Champlain region, that pharmacy is Royal Drugs. So all the medications come from Royal Drugs, but you don't have to worry about that. So that'll be all good. Then when the nurses show up for their visit, they're going to be able to teach the patient and family about the pump. They're also going to monitor the pump and the patient daily, and they're going to communicate with you if a titration or if a refill is needed. So also too, with Royal Drugs, and I work with them extensively, they're very good to reach out. So if they have any questions about the orders that you have, I always say like put your actual number on the bottom of the form so I can give you a call. They're very good, and they'll walk you through. They do it for me all the time too, and I order these things like on a daily basis. So don't feel overwhelmed or stressed. So some pitfalls. So the big thing that you want to make sure that you're doing is that you're indicating on the form when you want the pump to be delivered. More often than not in our situations when people are having difficulty with swallowing their pills or losing PO route, it's usually more urgent than not. So if you do put on it and say urgent, please deliver as soon as possible and coordinate with a nursing visit, usually it can be done within 4 hours. Incomplete forms can cause delay, which is the same with any kind of prescription that anyone would be sending in. And different medications come in different pre-made concentrations. Again, pharmacy is very good to reach out. So if there are, sometimes they have pre-stock of certain concentrations for some medications. So you might put something down. They say, oh, actually, this is what we have in stock. I usually just say, yes, please, thank you. I appreciate the call. And they're very good to help out with that. So the key takeaways. So CADDs are safe and effective for continuous subcutaneous drug delivery and palliative care. So they enable flexible, patient-centered symptom control when people are losing their PO access. Training and compatibility are crucial to minimize errors and site complications. And emerging evidence supports their use for complex pain in the home with appropriate support. So let's put this in with our case. So with Mrs. LM, she's super nauseous. She's not able to take her PO medications. Oral intake's declining. She's super fatigued. She's having this uncontrolled pain because she's not able to take her PO meds anymore. So what do? So after kind of doing the calculation, so we go through, we figure out our total daily dose. We figure out what the basal rate is going to be, which is going to be 1 milligram per hour subcutaneously. We figure out the PCA bolus is going to be 2.5 milligrams, Q60 minutes PRN. always doing proper. So any opioid always need antiemetic on board with it, as well as bowel regimen. The nice thing is that nursing is going to go in and have daily reassessment for pain and sedation. Our goal is that she's consistently comfortable by reducing the pill burden and improve quality of life. So the big thing to kind of take from the teaching point from this is when the mouth says no more pills, let the pump do the talking. That was pretty quick. Anybody got any questions?
A few things that have come up in the chat, and Laura's just popped in a little
Oh, hey,
answer.
Laura.
So Laura Hamilton works at Ontario Health at Home here in the Champlain region, and hope you don't mind I called you out. But just to say, because we have folks from kind of all over the province and beyond
Okay, sure.
that have signed on. So different comments about that there are maybe regional differences in the forms,
Yep.
and there also may be regional differences in the pumps depending on the vendors that are at play in the region. So
Yeah.
and I think one of the comments early on was just about also the convenience for opioid titration. Just how much easier it can be to see like how much somebody has had in the previous 24 hours and then, titrating up according to need. I don't know if you want to
Yeah.
comment on that.
Yeah, exactly. So the nice thing with the pump is basically anytime that pump is used or the patient's using patient-controlled analgesia, it records it. So it's very nice. You can actually interrogate the pumps, or in some instances, if the visiting nurses are there, you can actually go through and it'll actually say how much has been given in the last 24 hours, say, which gives you a really good sense of, is this pain under control? Is it not? Do I have to go up? Do I have to go down? Also, the nice thing too is with the nursing visits as well, they're kind of their eyes and ears, and they're able to inform you if they are developing toxicity or anything like that. And I know, yeah, and so I just used the Champlain region as kind of an example. The core concepts of being able to kind of figure out what the total daily dose and kind of figure out the basal rate and things like that would kind of apply to the regional differences. Thank you, Laura, for adding that to the chat.
Somebody asked about, is it okay for family members to do the
Hit the button.
PCA doses if the patient's not able to hit them for themselves?
Yeah, it's a good question. So in the community setting, yeah, so really that's kind of context specific, I guess, of where you're practicing. So in the community, like say if somebody's at home, usually that's what we would say that can be used for if they look like making sure that there's education for the family that's there. Again, we set the parameters that it locks out so it's safe. In some hospital settings, it's a little bit different. We would put things like clinician boluses and things like that.
And Gabrielle just mentioned that there is for some pumps, there's an adapter where there's like actually, something that plugs in that creates an easier way to push for the PCA dose than
we call it the wand. So it's so instead of actually having to physically touch the pump, you can actually get a kind of a cord with a button on it. So sometimes in the hospital, the patients will confuse it for their call bell. So
yeah. There was a comment about just in the rural areas that sometimes pumps can take longer. So with
yeah, and again, that for sure, yeah. So that can definitely dependent on where you are. Yeah. So good
So
point.
that idea of anticipating, like trying to think ahead even more so, eh? But somebody was just asking about like, does the pump limit the patient's like activity? Like they can get up and
Good question.
about and
no, like so really it kind of depends on the patient. Like I've had some patients that I've had like they still go for bike rides. Like I said, like a lot of people will just kind of wear them in a fanny pack. That being said, like if the patient was kind of frail and to begin with, like of course it is something else that's kind of there and they're kind of tethered to. So you just have to be conscious of them getting around and making sure that they're aware that it's there and that it's not getting either caught up on things or getting stuck. If they're already in kind of or if they're already having difficulty with navigating their environment due to either frailty or progression of their disease, it's just something to be conscious of. So it can, in some cases, depending how fit they are, I guess, at the point, it can be, yeah.
And then there's another question about, are they waterproof and do they need to be kept in any position to
Yeah,
function
no,
properly?
I know they can be flipped upside down and all that fun stuff. We usually like advise, I know when I'm seeing patients in the community, like it comes with a long enough cord that people can, sorry, long enough tubing, I should say, not cord, that people can actually go into the shower and able to do bathing and things like that. So we usually just say to kind of keep it out. But if it did got, like if it got splashed, it would be okay.
Um, Somebody asked about the dosage judgment. Somebody said it's like a concrete Game Boy. I love
Yeah,
that.
exactly. That's a good one. Yeah.
Um, the if you were prescribing IV instead of sub-Q, what would
Yeah.
be the adjustments that you need to make?
Yeah. So for simplicity's sake, just the same. So
Okay.
typically what we'll say is just it would be, so if you're going either from PO to IV, it'd be the same as going from PO to subcut.
And the last one is, what do you make sure that there's available in case there's a pump failure?
Yeah, so a good question. So on the actual form itself, at the bottom, you can kind of go swing back to that. There is a contingency order that's there for pump orders. So again, this is probably dependent on where area you're in. But it'll say contingency order on the bottom. Basically, you just use the same drug. And then what you would do is you would just kind of go back to what your subcutaneous and intermittent injection would be. And usually we kind of give like a 24-hour supply available just to until they can either get another pump out there or a nurse to come visit to make sure that it's fixed. So in our case, like if we were running it at 1 milligram per hour, you could say you could give them, 4 milligrams subcut Q4 hours, and then you give them enough for 24-hour supply, so 6 doses of it.
Right?
Yeah,
I think we can go on.
perfect. Great questions. Thanks. Everyone's really engaged. This is excellent. So for our next section, we'll talk about methadone. So I think this is what probably most people are interested in. So methadone is a medication with a reputation, but it's palliative care's secret weapon. So full disclosure, I love methadone. It's a great medication, especially in palliative care. And hopefully we'll be able to kind of convince everybody. So got another Zoom poll for everybody. So which of the following statements about methadone is a myth? Please select all that apply. So A, methadone can only be prescribed with a license. B, methadone has fixed conversion ratio from other opioids. C, methadone can safely and effectively be used for cancer pain. And D, methadone can help with both nociceptive and neuropathic pain.
Okay, looks like most people have answered, and we'll give it one more moment here.
Good. All right, yeah. So trick question. There's two right answers. So I just wanted to make sure that people were paying attention. So got people thinking. So that's excellent. So methadone can only be prescribed with a license. That's a myth. We'll get into that. And then methadone has a fixed conversion ratio from other opioids. That's also a myth. Good. All right, so let's paint a picture of someone who may need methadone. So this is Mrs. DM that's in the community. This is my first time using AI picture, so I just want to throw that out there. So case that we have, so it's a 68-year-old lady, metastatic pancreatic cancer. Currently, she's on very high doses of hydromorph. So she's taken long-acting 24 milligrams twice a day, which is equal to about 200 to 250 milligrams of oral morphine equivalents a day. With her pain, she's having mixed nociceptive and neuropathic pain. She's getting escalated opioid side effects. She's getting sedation, myoclonic. She's getting poor sleep. She's tried everything from gabapentin to loxetine. Nothing's really helping. So The problem we're getting into is that despite appropriate opioid escalation and adjuvants that have been tried, her pain is still 6 to 8 out of 10 with significant neuropathic burn and tingle. And our current strategy is maxed out and starting to cause harm. So this is kind of a classic presentation that we would see for someone where it would be, okay, maybe I should be thinking about methadone. So just to get into a little bit of the brief history of methadone. So it's actually not a new drug, even though it seems like in palliative care, it seems to be newer than not, or maybe in different prescribing practices in different places. So it was originally actually invented in like late 1930s, developed in Germany, and it was a synthetic opioid, basically looking for an alternative to morphine that would be able to be used that's easier to give to people basically in World War II. So is it introduced in the United States and just after World War II. Originally it was called Dolafine. And early clinical uptake was pretty modest. In the 1960s, 1970s, there was some landmark work that was done by Dole and Neiswander, demonstrating that it's had effectiveness for opioid dependence, just due to its long acting and it's able to reduce cravings for opioids. And this is when we kind of saw this whole big, huge kind of shift in the use of methadone for maintenance programs for people with addictions. So, this continued on for about 20, 30 years or so. As you know, culture shifts take a very long time. And usually when myths get dispelled, it takes 40 or 50 years later down the road. A lot of times when people hear methadone, the first thing they think is addictions, right? Not so much for the pain part of it. But in the 2000s, we kind of see there was a reemergence of methadone use in pain medicine, particularly oncology and palliative care. Reason why is just its unique receptor profile, which we'll get into in a bit. It's a long half-life and its role in opioid rotation. So when people are getting toxic, it's something that was found to have pretty good results to get people better under control and out of toxicity. So presently it's used, selectively for refractory pain and opioid use disorder, requiring careful dosing and monitoring given its variable pharmacokinetics. So this kind of gets into our myths. So like I said, first thing, whenever I talk to patients all the time, the first thing is like, oh, methadone, I can't go on that. I'm not addicted to methadone. Am I going to get addicted? No, you're not, right? So it's actually a fantastic analgesic. So the nice thing is it not only has just nociceptive kind of activity, it's also great for neuropathic pain. So kind of that nerve pain that's traditionally very hard to get on top of. So, people that have, that burning, tingling sensation that not really responds traditionally very well to opioids, methadone's a great option for them. Another myth is that, I can't give them methadone because it interacts with every single other medication under the sun. So, it does interact with a lot of stuff. I'm going to give you guys or give everyone some tips and tricks on kind of what ones to be aware of, but it's not a deal breaker, right? So it just requires awareness and a bit of homework. In regards to QT prolongation, yeah, QT issues are possible, but really clinically significant events at the doses that we would use in palliative care are pretty rare. A lot of that literature actually comes from addictions medicine, and they're using doses that are way higher than what we would traditionally be using in analgesia. Screening is reasonable, but it's not a barrier. And then for elderly patients, you can't give it to someone who's elderly or frail. Actually, these are probably the people that would benefit most from it. Same thing as with any other medication, just start low, go slow. And you need a special license to be able to use methadone. That's actually a myth. Back in the day, probably 10, 15 years ago, and again, it was more so for the addictions part of things. That might have been the case, but here in Ontario, anyone can prescribe methadone. There's no barrier to that. There is something, however, that some people would be sometimes kind of confusing with, and this is called the Palliative Care Facilitated Access So basically what this is, it's not a license or anything like that. It actually just gets the methadone covered for your patient, so it's free if they're taking it for palliative care. So one thing, and this is a link if anyone is a prescriber here in the audience, what you can do is you can actually click on this link. It takes probably about 5 seconds. All you got to do is just put in your demographics on the bottom. It's going to say, there's going to be criteria to say, oh, if I fill this out, then any of these methadone would be covered and be free for the patients that I prescribe it to. Really, all you have to do is you have to say that you're working in collaboration with a palliative care physician or PCFA approved nurse practitioner, or it's you're doing, you see more than 20 palliative care patients, you've done palliative care consult, you've been designated. There's a whole bunch of criteria. And then basically, if you kind of click off on any of those, you'll get approved and basically comes back 2 days later, and then you're able to prescribe for free. Oh, thanks, Val. Appreciate that. Good. So again, I would encourage everyone to go, if you are a prescriber, to go and get this. So it doesn't only just cover methadone, it also covers other palliative care medications as well. So things like oxycodone is also one of the medications that's covered for patients that are on there, and some other ones as well. So why is methadone so special? So big reason why. So one thing that we always kind of I like to mention, especially when I'm educating people about the use of methadone, is that the half-life is enormously variable in different people. It can be anywhere from 5 to 130 hours. So I don't really know of any other medication that's got such a wild half-life and such a wide range. So this is part of the reason why we treat it so carefully. Because basically, if you take the pill now, you're not going to really see the effects until, in most cases, 2 to 3 days later. So it's a little bit tough to be able to get that correlation, right? Because what I change now, you're not going to see within 20 minutes. It's going to be 2 or 3 days later. So then if you think of steady state, so usually we say for a steady state, you have to have 5 to 6 half-lives, and that's when things kind of get good enough in serum level that it'll build up, so you're getting that analgesia. So the range to get to steady state would then be huge, right? Depending on how it affects that particular individual. So another really interesting thing about methadone is that you see it prescribed daily, typically in opioid use disorder or in addictions. So this works to block cravings for more than 24 hours. For us in palliative care, though, we typically dose it differently. Usually what we say is that the duration of the analgesia from when you take a pill, you usually get about 8 hours or so of analgesia for most patients. So usually, typically, we prescribe a Q8, although in some cases you can do Q12 or Q6, depending on the situation as well. The other thing is that there's no linear conversion from one opioid to another. So instead of being, 5 milligrams of methadone is equal to X amount of hydromorph, actually with the higher doses that you get, it gets skewed. So it's logarithmic or exponential in some cases. So that can make it a little bit more tricky as well. But hopefully, I got some tips and tricks that we're going to be able to make it a little bit simpler for everyone, so you're more comfortable with it. So who's going to be potentially appropriate for methadone? So typically what we're looking for is someone who's moderate, severe, refractory pain. They got renal impairment. They need a long-acting opioid, high opioid tolerance, and they have neuropathic or complex pain. So who's not good for methadone? So big reasons why would be someone who lives alone or is isolated. Again, kind of going back to saying if we make changes, sometimes it can be a while before we see what kind of the effect would be. So we want to make sure they're not living alone. If there's someone there, let's be able to keep eyes on them. Also, another kind of not great situation is care transitions. So a lot of times, or in some cases, someone might be prescribed methadone, say in hospital, and then they are going back home. Their pain's great, it's under control, but then the prescriber, or say like their family physician or nurse practitioner, is not comfortable with methadone. That can make things kind of tricky. So just making sure that you always have the next plan of who's going to continue to prescribe the medication is important. So people that have known QT prolongation, something you want to be aware of, as well as structural heart disease, sleep apnea, prognosis less than their steady state. So if someone's, their prognosis is probably less than a week, methadone is probably not going to be able to take effect. So that would be beneficial for them. And then also if they have any previous history of opioid non-adherence or substance misuse, that's also would be kind of a contraindication, because if they're not using their medication or the methadone reliably, it can get dangerous pretty quick. So you just have to make sure that adherence is there. So given that by definition in palliative care, patients we care for have serious illness, let's talk about how to handle comorbidities when thinking about prescribing methadone. Let's start with the kidneys. So methadone is actually metabolized in the liver. So as opposed to other opioids, which are metabolized in the kidneys, they're actually where their metabolites are excreted in the urine and feces. Kidneys don't really have a major role in playing in clearance. So this actually makes methadone a pretty useful opioid to consider for patients with renal impairment, even people that are on dialysis. So if someone does have severe renal disease, it's recommended, to be cautious with dosing, but really we're not as worried about it as what we are with other opioids. And just as a note, only 1% of serum methadone is actually cleared when they are on dialysis. So that's actually great, because if they go for dialysis, you don't have to worry about that they're going to get flushed out and then they're going to go into a pain crisis, because the methadone is still going to be there to help out with their pain. So people with liver disease, as I previously mentioned, one important characteristic is that methadone is that it has a very high bioavailability, meaning that methadone you take in, for most people, between 78 and 80% of it will actually enter circulation and has a minimal first pass clearance, meaning that the liver doesn't remove much of it before it hits circulation. So metabolism does depend on cytochrome P450 system that's in the liver. So metabolism is actually decreased in cirrhotic patients. So we always suggest to avoid methadone in people that have end-stage liver disease or cirrhosis. But, as long as you're cautious and conservative and depending on what their goals of care are, it's something that can potentially still be used. Also, the other thing to kind of be aware of is that because they have renal or hepatic impairment, it can take almost even longer kind of reach steady state. So sometimes 2 weeks or so. So again, start low, go slow with dose increases. So people that have substance use disorders, ideally you'd be able to co-manage with an addiction specialist if it was possible. If they do have any other active illicit substance use, I would avoid using it. And that just kind of goes hand in hand. Again, just because with this medication and because it's not predictable how long it lasts, things can get dangerous in those particular patient populations. History of sleep apnea. So this is actually a funny one. I kind of joke when I'm on the palliative care unit, when I'm working there, that when someone has started on methadone and they have untreated sleep apnea, because you can hear them snoring down the hallway. So not uncommon that methadone is actually associated with sleep apnea. So if they already had sleep apnea to begin with, just be careful with that, especially if you're using other things like benzodiazepines. That's an additive effect. And, so just avoid mixing methadone and benzos with people if they're not properly treating their sleep apnea. And what about the QTC prolongation? So we do know that methadone inhibits expression of potassium channels, which inhibits repolarization. So we do worry about QTC prolongation leading to arrhythmias and potentially death. So usually what we kind of say is if they got a QTC between 450 to 500, look at other options or other alternatives. It's greater than 500, usually just avoid methadone. The good thing is though, is if you did start it, say, and then you did an EKG or an ECG, sorry, it is reversible if you do stop the methadone. And really, to be 100% honest, again, like I had previously mentioned, a lot of the studies that we have in regards to the QT prolongation are in doses that are far in excess of what we'd be using in palliative care for analgesia, more kind of come from the addictions world. So there is, a lot of the studies do suggest that there's a dose-dependent relationship, but really it's not until you're getting more than 100 milligrams in a day. And then in regards to cardiovascular disease, heart failure in and of itself is a risk for QT prolongation. So again, just being cautious in those patient populations. So talking about the QTC, talking about coronary artery disease, there was a pretty good paper that was published by McPherson et al. Back in 2018. So it was titled basically the use of methadone in hospice and palliative care, expert consensus white paper. This is actually a great paper. It has a pretty good kind of walkthrough, and I've actually kind of adopted quite a few of the guidelines that they had from the paper and for the use of methadone and for things like monitoring. So basically, this table just kind of shows like how vigilant you should be with monitoring for things like their QT. So the highest level of vigilance. So for patients that are undergoing curative or life-prolonging treatment, where methadone is used as first-line treatment, those would be the people that you'd want to be, doing pretty regular. You want a baseline EKG, then you also want to make sure that you're kind of doing repeatedly when you kind of reach 30 milligrams a day or 100 milligrams a day. Then as you kind of go down with lower kind of levels of vigilance, for people that their goals are purely for comfort, they just want to make sure that their pain is under control and, making every day the best day that they can. And those people really, you don't have to do any EKG monitoring. So what about medication interactions? So, so for medication interactions, there are many medications that interact with Medicote. And you know what, to be 100% honest, it's really hard to keep track. One thing that actually came from the white paper that I previously mentioned is the 3 A's. This is a great tool that everyone can kind of use, and hopefully you can take a snapshot of it if you want, take a picture and kind of keep it on your phone. That's what I do. So the big 3, so there's kind of 3 big ones. These are amiodarone, anti-infectives like Cipro, ketoconazole, erythromycin, antidepressants. And antidepressants would be the 3rd one. So basically, if you kind of keep these 3 in mind, so basically antidepressant, anti-infective, amiodarone, the suggestion for those one is just whatever your calculated dose is for methadone, just reduce it by 25%. And then usually that's a pretty good way to go about things. Good. So how to start methadone. So this is a busy slide. Don't stress out. We'll walk through it. It'll be pretty easy to get through. So basically, this is a cheat sheet that kind of summarizes the most important points for safely starting and increasing methadone for pain. So we'll go through this in more detail and kind of walk through. So according to the white paper, for dosing, we'll kind of start and actually kind of work through this table that's here. So basically there's 3 kind of ways of being able to convert someone from an opioid that they're previously on to methadone. So this table is super simple because there's only really 3 things you have to think of. And one of them is no conversion. So that's pretty simple. So let's go through it. So on the first column on the left, so that's what the patient's current opioid dose is per 24 hours in oral morphine equivalents. And then basically we have it divided up into someone that's opioid naive, which includes patients using up to about 60 milligrams of oral morphine a day. Then there's the middle, which are people on 60 to 199 milligrams of oral morphine who are younger than 65. And then the most conservative conversion, basically at the bottom there, for people on higher dose opioids, more than 200 milligrams of oral morphine per day and older than 65. So basically, the middle column shows the actual conversion that's in this table. You see if someone is in the top row, opioid naive or less than 60 milligrams, there's no conversion that's really needed. You just start really low dose methadone up to a maximum of about 7.5 milligrams per 24 hours. So some examples of doses you might see for someone who's not using much opioid and they're they're kind of opioid naive would be kind of 1 milligram PO Q12 hours or something like 2.5 milligrams Q8 hours. So for the middle category, in the middle row, patients younger than 65 on a moderate opioid dose between 60 and 199 milligrams. Basically, you would just divide their oral morphine equivalents by 10, and that's going to be your 24-hour methadone dose. So an example, start a low dose, you might come up with here would be something like 5 milligrams PO every 8 hours. And then lastly, for the people that are the most conservative, so they're on a lot more opioid, so greater than 200 milligrams of oral morphine equivalents, you basically divide that by 20 to find the methadone dose. So the big thing of note in this is that regardless of what number you come up with, it's never recommended to start anyone on more than 40 milligrams of methadone per 24-hour period. So at a higher dose, I would say probably a good starting point would be like 10 milligrams PO Q8 hours, and then you kind of slowly titrate up from there. Good. So that's that. So now that we figured out how much methadone we're going to kind of convert them over to, how do we actually do it, right? Because if they're on an opioid already to begin with, and I got to get to methadone, and I know that it's going to take a while for it to kick in, what's the way to be able to do it? So this table here shows the Edmonton method. So this is a pretty accepted, and to be honest, probably the most common way that a lot of people in palliative care will convert someone from one opioid to methadone. So basically, here on the table, we have 4 days that are represented. So day 0 represents the day before you're going to start methadone, and day 1 is the first day of methadone. So you have your scheduled opioid. So you generally your long-acting or continuous infusion. Then basically you have your methadone dose, and you have a short-acting PRN. So basically on day 0, patient's going to be on 100% of their original opioid, right? And then basically what we're going to do is we're just going to add in basically a third of the opioid, decrease the original one down by a third. We're going to add another third the next day, or decrease the original opioid down by a third, ultimately until we completely flip them over to just methadone, and then they're on nothing of whatever the original one was. So basically the easiest way to kind of think of it is that, so every day I'm going to go down by a third on the original, and I'm going to increase by a third on methadone until I get to 100% conversion. So it's kind of going down on one, up on the other. So this is a pretty good important table. So like for me, anytime that I'm actually kind of trying to figure this out, what my conversion is for the actual Edmonton method, I actually write it down so I know what day 1 is. So like day 1, say it's going to be 50 milligrams of morphine. We're gonna have 2 milligrams. I'm just making up numbers. This might not actually work out, but I know 2. Then I'm going down to 25, say, and then I'm going to go up to 6, and then I'm going down to 0, and then basically I'm up to 8 of nothing. So a little bit confusing. These are here for reference. There's also an excellent resource that I'm going to share with everyone later on called methadoneforpain.ca. It's offered by Canadian Virtual Hospice. That also has a very good teaching module that you get CME from as well. And they help out with those things as well too. So what do we do if you want to increase the dose? So basically we generally wait about 5 to 7 days before increasing the dose. because we want to make sure that we've reached a steady state. Remember, again, I said has super wild half-life, ranges in different people, so anywhere from 5 to 130 hours. Usually on average, it's about 35 hours or so. So basically, and as I said previously, so one single dose of methadone will usually provide analgesia on average about 8 hours or so. So I do this thing that I like to say is methadone Mondays. So anytime I'm going to kind of increase their methadone dose because their pain is not controlled, I like doing it on Monday. The reason why I like doing it on Monday is because then I have all week to kind of see what the change is going to be. Never change on a Friday, because if you change on a Friday, if something happens over the weekend, you have to get a hold of people. So that's pretty much true with anything you do in healthcare. Don't ever change anything on a Friday. Never discharge anybody on a Friday. Those are my two number one tips that I'll ever have. So yeah. The second kind of point here is, increase by a max of 5 milligrams in 24 hours, up to about 40 milligram dose. Don't ever kind of increase more than that. And the big thing, increase 10 milligrams in 24 hours, and anyone that's in beyond the 40 milligram dose. Okay. So I know I just explained a whole big, huge, confusing way to be able to convert someone from one opioid completely over to another. And now what I'm excited about, and this is something that I actually prefer doing. So there's been a lot of new papers, a lot of new research, retrospective analyses and kind of observational studies that are showing that low dose methadone added on to another opioid actually has pretty good effect. So low dose adjuvant methadone. So basically, a lot of the studies are showing promising evidence that small doses of methadone, so in some cases, like even 1 milligram just added at nighttime, on top of whatever their normal opioid regimen, has super good effect. So you get all the benefits of having things like the NMDA receptor activity, so for that neuropathic pain, without all the complications, like things about worrying about the QT prolongation. It's also shown to be opioid sparing. A lot of these studies have shown that pain intensity decreases significantly. It ranges in some of the studies, but most have a pretty good response. Most have actually an even earlier response than what we typically would see, because it's kind of working in kind of synergistic effect. And I actually do this quite often. So for patients I find that have very complex pain syndromes, that I'm or in the community particularly, it's super safe. You can just give them 1 milligram QHS of methadone, at nighttime, in addition to whatever pain medication that they're currently on. You don't have to worry about switching anything. You just put it on top. That's it. And then usually within about a week or so, you kind of have an idea if things get a little bit better or not. And then you can just kind of slowly increase it to say like 1 milligram 3 times a day. Usually I just kind of increase by 1 milligram slowly. And it actually has very good benefits. So for people like that have squamous cell carcinomas of the head and neck, usually there's super complex pain syndromes. Same with people that have kind of anal or rectal cancers, because it's just a lot of plexus involvement. Methadone at low doses like this actually works excellent. So chatted a lot. Let's put it to practice. So we go back to our Mrs. DM who's in the community. So as everyone remembers, she's the person that's starting to get a little bit toxic. We're kind of getting maxed out on what our current opioid medications are. So methadone, the right tool for the pattern. So why methadone fits in this scenario? So the dual mechanism of the mu agonist and NMDA receptor antagonism. So it's ideal for mixed neuropathic pain. Also can address the opioid-induced neurotoxicity. It's opioid sparing, so we can actually reduce the amount of hydromorphone, hopefully, that she needs. Has nice, long, steady coverage. So again, we get less or fewer peaks and troughs because it's working in a longer fashion. And it's feasible and inexpensive. So thing to kind of remember is someone that's got high opioid requirements, neuropathic pain, neurotoxicity, methadone really adds value. So for this particular patient, one thing I would kind of suggest, in particular if people aren't super comfortable in flipping them over completely, if anyone ever did have questions about that or wanted to, certainly you can reach out to us, and I'll provide contact information for the regional palliative consultation team. But usually for this instance, what I would do is start somebody at 1 to 2 milligrams PO daily, keep their baseline opioid initially, reassess it 3 or 5 days later, kind of titrate it slowly. So some people, like, to be quite honest, I've had people that their pain is wildly improved and actually decreased the amount of their regular opioid that they would be on. Just big things you're doing, like with any opioid, you're monitoring for sedation, interactions, QT risk factors. Again, going back to using kind of the vigilance that we need, depending on what their goals of care are. So yeah, so the expected outcomes, much better neuropathic pain improvement, lower overall opioids needed, reduces neurotoxicities. And so basically when opioids plateau and neuropathic pain rises, adjuvant methadone can shift the whole trajectory toward comfort. Any questions?
There's been more than one come up.
Oh, geez. Okay, let's go.
It's all good though. They're good. So somebody kind of talked about the scenario of somebody who's on methadone maintenance therapy, and then they have cancer, and would the methadone be an option for pain management, or would you look at other opioids? How would you proceed?
So the question was someone that's on maintenance therapy for like
substance use
disorder.
Use?
Okay. Yeah, that's a good question. That's kind of beyond the kind of the realm of this talk. Usually what we kind of say in people that have substance use disorder, the simple way I'll kind of put it is like, what I would typically do is same as if you're just titrating, if someone else had pain with any other opioids, you kind of increase by 20% or so, whatever their current maintenance dose is, to see if they would have. Again, the big thing that comes into play there is you want to make sure that there's the safety component. If they're on a contract previously, those are other things you want to take into consideration. You'd still want to do things like doing your, if they're getting daily carries, probably wouldn't want to do carries, or you'd probably want to make sure that it's like a witness dose or what have you. But again, that's a whole kind of other, but I hope that kind of generally answers that question.
Yeah, that's probably a whole other presentation. Another question was around, there's certain stigma associated with methadone because of the, kind of folks that we just described. And so, like, has your experience been that, when you propose methadone, that people maybe need a little bit more explanation, or people more concerned about addiction with methadone than other opioids? What have you kind of seen in relation to that?
Yeah, I always, so again, I bring up methadone not infrequently for a lot of the patients that I care for. And, I usually typically kind of preamble it. Like I say, what, there's a pain medication that I know that's actually originally was invented for a pain medication for cancer pain. But then it kind of got adopted for addictions. So there still obviously is a stigma that's for it. But the reason what I'm using it for is actually because it's an excellent pain medication. I'm not using it because the person is addicted. Because a lot of times patients will confuse, and this is the same with any opioid, right? They'll confuse tolerance with addiction. So people think that, oh, I'm going to need more and more opioid as I go on. That's just tolerance, right? So that just means that your body's getting used to it. You need more of the medication to get the same effect, to get your pain under control. That's not an addiction. So I always kind of, whenever I'm suggesting it as a potential option for patients, that's usually what I say. And to be honest, I've never had anyone that's been like, oh, I can't do that. People are actually, we usually, when you're reaching for methadone, they're in pain. And this is just another tool in the toolkit to make sure that we can make their lives more comfortable, right?
So is there a difference between like the tolerance that you would experience with methadone and other opioids?
Yeah, it's a good question. So with any opioid, like you would expect, as time goes on, they're going to, probably you're going to have to uptitrate things as time goes on. As far as like as a comment, like I don't think there's any data off the top of my head that I can think of that people get quicker tolerance to methadone. If anything, because it's so long acting, it would actually probably be a lower tolerance rate than what a typical opioid would be, right? Because they're longer acting than what kind of conventional opioids are. But I'm kind of shooting from the hip. I don't know any data off the top of my head.
It's okay. Somebody asked about, what factors influence the half-life of methadone, anything related to age, weight?
Yep. So the big things to kind of take in consideration, like I kind of mentioned, where if they have liver issues, that's a big one that's going to affect what the half-life is. Age and weight, again, same thing I would take in consideration with any kind of opioid that I'd be using. Start low, go slow. If I wanted to even just use adjuvant medication in someone that was like fairly frail, fairly petite, doesn't have much muscle mass, cachectic, even like 0.5 milligrams, that would be a good starting dose. So it's just as a quick equivalency, like at that low of a dose, that would be equal to like 1.5 milligrams of morphine at 0.5. So just start low, and then you can kind of titrate up as needed. And again, like I said, the medications, so the 3As, those are the medications as well that kind of be aware of. So you always want to make sure that you kind of reduce your dose and see what the effect is.
And then the last question was kind of around respiratory depression. Like with that approach, the start low, go slow, like clinically, do you see much respiratory depression?
No, I mean, it would be the same as any other opioid, right? If you start off way too high, that would definitely would probably cause more respiratory depression in those cases. But again, everyone's well trained. And the whole reason we're doing this talk is to make sure you start low, go slow. Very rare that you'd get any kind of worsening or easier respiratory depression as compared to other opioids.
There was another quick question came in. So
Sure.
What's more likely to cause delirium, hydromorphone or methadone?
That's a good question. So I don't think that's
One
a
more
tough one,
than the
right?
other?
Yeah, not one more than the other. So delirium is never just one thing that causes a delirium, right? So on average, most literature and studies show that delirium is usually precipitated by like minimum three things are kind of gone wrong that's precipitating delirium. So you can never really kind of just attribute to just one thing. So yeah, and in my experience, to be quite honest, like there's other reasons, not just the opioids that are causing a delirium, right? So
Awesome. On to ketamine.
perfect. Right.
I think it's ketamine, right?
It is ketamine. Yeah. Yeah. Good. I'll keep on going. So ketamine, from club drug to comfort care. So another Zoom poll for everybody. So what best describes your impression of ketamine and palliative care? So it's mainly a last resort analgesic. It's mostly an antidepressant. It's useful for both pain and mood. It's too experimental for routine use. I'm not sure how or when to use it. Good. Okay. So a lot of people think that it's good for pain and mood. That's great. That's good. So people aren't going to be surprised then about what I'm about to say. So yeah, we'll get into that. So again, another case, Mr. BK, who's in a palliative care unit. So this is a 58-year-old man with metastatic colorectal cancer, extensive pelvic and perineal metastases. So his symptoms, he's got severe burning and shooting pelvic pain, neuropathic. His pain score currently is 8 out of 10, despite hydromorphone 1.5 milligram per hour on a CADD, with 4 milligrams Q1 PCA subcut, PCA bolus. He's on gabapentin at 900 milligrams POTID, and he's on duloxetine 60 milligrams PO daily. So right now his function's pretty disrupted. He's having difficulty sleeping. He's got awful mood, and he's unable to sit or move comfortably. So let's just keep Mr. BK in the back of our minds there. So ketamine. So I see in the chat there, some people have kind of referenced it as Special K. I think most commonly people kind of know it as, horse tranquilizer. There's a ton of different names it's kind of gone by over the ages. So as far as kind of its history, so it was actually kind of developed in 1960. It was actually developed by a chemist, Calvin Stevens, and also at Park Davis, when he was looking for a safer alternative to PCP, actually. So at the time, when they were kind of researching and kind of developing PCP at the time, they knew it was an excellent anesthetic, so being able to put people to sleep, but it had caused prolonged severe psychosis, unfortunately. So what these researchers were doing is they're trying to figure out a way to be able to get people to sleep, but then that they didn't have the kind of more dissociative effects or kind of the psychosis that was associated with it. So in the 1960s, kind of mid 1960s, they had their first human use. So initial clinical trials actually showed that it was a pretty rapid onset, is pretty reliable. Really what they found is that it was very good for people to preserve their airway reflexes, and it was also cardiostable, making it a pretty good way to be able to get people to sleep. The 1970s, it was actually adopted, particularly during the Vietnam War. It's kind of the staple anesthetic in field combat and trauma. Reason why is because it was able to maintain blood pressure, support their breathing, so people didn't have to be intubated when they were on it, and also avoiding the need for complex equipment. So make it pretty ideal, so they could put people to sleep, fix them up, and then get them back out pretty easily without having to bring them into almost ICU settings. Then it wasn't until about the 1980s or so that we saw there was a shift in its use. So because there was some psychomimetic effects, or kind of like psychotic type effects, or kind of hallucinations, or what we call emergence reactions, became more recognized. So ketamine was used in elective anesthesia, starting to get used less and less because people were starting to have more of these kind of psychomimetic effects that was being reported. But then there was interest as it grew with its sub-anesthetic analgesic properties, so helping out with pain. So if we weren't put to sleep, if you used it at lower doses, we had found out that it actually helped with people's pain, particularly in kind of neuropathic pain syndromes. So in the 1990s and 2000s, that's when kind of it was adopted more in pain, particularly in places like palliative care, as well as in psychiatry. So they found that ketamine's NMDA receptor antagonism and downstream effects worked pretty well for things like opioid refractory cancer pain, complex regional pain syndrome, and and also was pretty good for opioid sparing strategies. Also, at the same time, started to see it used more for treatment-resistant depression because that had a rapid and profound kind of antidepressant effect. And right now, kind of since about the late 2010s, it's kind of a key agent, particularly in emergency medicine. It's still kind of used for a lot of procedural sedation. So people coming in with like broken arms and they gotta get X-rays and things like that. Acute pain, chronic pain, palliative care, psychiatry. It seems like everyone loves ketamine. Everyone's using ketamine. So yeah, and now we're kind of see it more predominantly in palliative care at low doses to help with kind of neuropathic mixed pain syndromes. So how does it work? So basically, it's a lipophilic general anesthetic, like I previously mentioned. It works on an NMDA receptor, very similar to how methadone works, except it has a higher affinity and it's non-competitive. Also dampens the pathways that lead to neuroexcitability, often seen in hyperalgesia and central sensitization. So again, thinking of those patients that we have that are getting toxic or neurotoxicity is developing for opioids, ketamine will actually work on, will actually dampen down those receptor pathways. Also interacts with opioid receptors, has some weak muscarinic as well as dopamine, norepinephrine, and serotonin receptor activity. Is often described as being able to reset the pain receptors and pathways as if recalibrating them. So quite often, What we use it for in palliative care is if someone's toxic, what we think can happen, it's not super well studied, but basically if you put a little bit of ketamine in there, it'll actually knock off some of the opioids that are on those pain receptors, hopefully trying to reverse any kind of neurotoxicity that they have. So it crosses the blood-brain barrier. The nice thing about ketamine is that you can give it any which way you want. So the kind of the joke is if you can get it into the patient, it's going to work. So you can give it PO, IV, IM, subcut, rectal, intranasal, intrathecal. Intranasal, sometimes people kind of ask about that. Usually when I see that used, it's more so in like pediatric emergency departments, because basically you kind of get a shot of somebody's nose as if a kid broke their arm or something like that. It's kind of quick because then obviously kids aren't too happy getting needles. So pretty quick way to do. The nice thing is its onset, it's about 15 minutes or so. It usually lasts for about 2 or 3 hours. Usually when we're dosing it, it's kind of every 6 hours or so. Metabolized in the liver, no real effect on renal clearance. Doesn't really interact with any other drugs. Anesthetic dosing, so for pain, anesthetic dosing, so for sleep, or putting someone to sleep, is usually we use it in greater than 1 milligram per kilogram. Subanesthetic doses, which would be less than 1 milligram per kilogram, usually at like 0.1 milligrams per kilogram, is what we'd be using more so for pain. And the nice thing is that there's no withdrawal symptoms. So you can have someone on ketamine, run an infusion if you want, stop it. They don't get any withdrawal symptoms. So that's great. So this kind of gets into the next part with ketamine. So even in the palliative care world, so the big thing to kind of take into account in palliative care are patient populations, very difficult to do any kind of high quality studies in. So reason being is that ethically, it's tough to do randomized control trials if we're kind of looking to see if someone's getting any kind of pain benefit from a medication. And then also two, it's very difficult to be able to do longitudinal studies because unfortunately with our patient population, their prognosis typically isn't too long. So we can't get a lot of durability or kind of long-term data from that. So since so really ketamine kind of being used as it is, it's kind of off-label, but in the grand scheme of things, pretty much everything that we use in palliative care is off-label. So there's no evidence really for nosing in. There's actually no evidence really for a lot of the opioids that we use that actually helps with pain, particularly in palliative care. So you kind of have to take that in consideration. Since the 1990s, there's been tons of articles that have been published about the use of ketamine and various cancer and non-cancer pain types. Big thing that they kind of show is that the more rigorous the study, the more ambiguous the effect and the effectiveness is. So the question kind of comes is like, is there a role for ketamine in palliative patients? So here's a couple recent studies that have been published and a couple opinion pieces. So the first one there, it's controversies in palliative care. Authors, were analyzing the available evidence for subanesthetic ketamine and opioid refractory cancer pain. On the analysis, they note there's a huge divergence of opinion. They highlight lack of high quality trials. So again, you can't really do randomized control studies. So really all we're able to do are kind of retrospective or observational studies for the use of ketamine for refractory cancer pain. The second one, again, kind of reiterates the same thing. There's no real kind of consensus. And then the last one there, ketamine is an adjuvant for opioids and cancer pain. At the end of the day, they show there's not a lot of huge evidence. It's mixed. But the big thing to take into consideration is that lack of evidence of effect does not mean that there's evidence of lack of effect, right? So although we're not able to kind of provide these huge in-depth kind of analyses or research papers or anything like that, doesn't mean that it doesn't actually work if it works. So what's the kind of the general opinion in the palliative care world? Most people will kind of say ketamine works for some patients, but we haven't really figured out exactly which ones. So again, we can't really do head-to-head trials comparative of one kind of disease process to another. We haven't really figured out the right dose. and we haven't figured out an unanimous administration protocol. So, there's tons of letters and editorials have kind of argued. It's been used in every which way from simple intermittent nasal spray for incident pain up to 5-day coma therapy for things like chronic regional pain syndrome. So these are all the things that I always kind of like to say. That being said, though, it is used, and we do see that there's effect. So typically, why we consider ketamine are people that have refractory cancer pain and palliative care. Usually, we use it also as a strategy to deal with opioid tolerance. So if they're getting escalating doses of opioids, and we're kind of reaching a limit where I don't think we can go much higher than where we are right now. We got to figure out what we're going to do to kind of knock that back. It's also a part of management for opioid toxicity, like I previously mentioned, and it's a treatment for opioid non-responsive pain. So it's used for various challenging pain syndromes. So like, as I previously mentioned, ketamine also has been demonstrated to have an effect on depression and anxiety in patients at end of life. So this is kind of beyond the scope of this slide deck. But the thing that we always kind of say in palliative care is that we're not just treating pain, we're treating total pain. So ketamine, if it has been shown to have effect on things like depression and anxiety. So if you can treat the depression and anxiety and to treat the pain at the exact same time, that's pretty good. So you're hitting two major factors for someone's pain experience to make sure with one simple intervention, right? So that's why we always say it's pretty important. So what are the adverse effects? So first and foremost are the psychomimetic effects. I know it's tough to ask questions in the chat or anything like that, but has anyone ever actually seen someone use ketamine or go under ketamine or anything like that? No? Yeah. So I always kind of mention, so you got to make sure before you ever kind of start ketamine, you have to make sure they're in a good spot. So when I say good spot, I mean in a good, safe environment where they feel that they're comfortable, they're not in an excited state, so not super anxious, not already in a big, huge pain crisis or anything like that. And this is because of the emergence phenomenon. So if you do start someone in ketamine, it basically just kind of heightens, the thing that I kind of run it analogous to is like having a bad trip, because this is a derivative of PCP. So you want to make sure that someone's in a nice, calm, safe environment. So usually we like to make sure those are kind of there, because if they're not using it, it can make people more distressed. So you just have to be aware of that. Also good to have a good sense if they have any history of any kind of PTSD. That's another thing sometimes that can become uncovered and can be distressing to some patients. Again, we always try to dose it at a low enough dose that we're getting their pain under control and they're not getting that side effect. So again, start low, titrate up slowly. It's pretty safe cardiovascularly, as we previously mentioned. Very rare to get any kind of respiratory depression. Sometimes it'll cause people to be a little bit more nauseous. Again, you can just kind of give antiemetics along with it. Sometimes you get injection site reactions as well. And then lastly, there is some evidence that with prolonged uses of ketamine, long-term infusions can cause ulcerative cystitis. So what are some contraindications? So if the patient has a history of seizures or any kind of neurological impairment, such as a recent stroke, if they have increased ICP or hypertension, really the classic patient is going to be someone that has poor pain control despite high doses of opioids and adjuvants, neuropathic pain component, and concerns regarding opioid tolerance or toxicity, and they may be at risk of a pain crisis or in high distress. Methadone versus ketamine. So ketamine is a more potent NMDA antagonist. So really for ketamine, the nice thing about it is that when you start it, acts very quickly. So you know if you're going to have a good response or not right off the bat, as opposed to with methadone, as we previously mentioned, it takes a while for it to kind of kick in to get a good sense if it's going to work or not. So that way, because typically what we would do is we would do like an injection. You're able to kind of titrate it pretty quickly. So you can kind of be there at bedside with the patient, give a test dose, see if they respond to it. That works, great. Kind of slowly titrate up, as opposed to trying to tinker with it over weeks, as with methadone. The other thing too, so if a patient can't swallow, methadone probably not going to be a good choice for them, because right now in Canada, as it currently stands, we can only give methadone by mouth in a pill or liquid form. So in that instance, if they weren't able to, ketamine might be a good alternative instead, because we can give that by injection, subcutaneous, pretty much any way you want. So how to use ketamine? So in the palliative care world, there's kind of a variety of protocols. Like I said previously, there's various routes of administration. It can kind of range. Some kind of protocols that are out there, they'll say that you can do like a dosing by weight base. So like usually like 0.1 or 0.5 milligrams per kilogram, or a protocol. So you actually have a fixed total amount that you would do over a 24-hour infusion. There's no consensus on what the best regimen is. The big thing, though, that in most of these these protocols actually show is that you want to make sure that you have something else on board to keep the person calm, whether it's Haldol or benzo, just to help mitigate those psychomimetic effects. And then as far as monitoring, really it's pretty stable, but it's always best practice and stuff like that to kind of take routine vitals as they're on ketamine. That being said, though, pretty rare to have. It's pretty cardio stable. It's pretty respiratory stable. So if you're in a pinch, you'd probably be okay. Just as long as you're monitoring and starting low and going slow. So there's two kind of protocols that are probably the most common ones that you'll kind of come across. One is called the burst ketamine method, and then the other one is continuous infusion. So for burst ketamine protocol to be able to give to patients, this was actually developed by Jackson and al. Back in 2010. Basically, what you do is you have a starting dose of about 100 milligrams that we give over basically an 8-hour period. And then basically you do it over 3 days. So day one, you start at 100 milligrams. Day two, you do 100 milligrams. Day three, you do 100 milligrams and you stop. If they have a response to it and their pain gets better, great. A lot of times evidence will kind of show that they can have durability of the ketamine and kind of burst protocol for anywhere up to a couple of months or so, kind of varies depending on the person. The thing is, if you do day one, 100 milligrams doesn't work, then you go up to 300 milligrams, day two. And then if that doesn't work, you go up to 500 milligrams, and you give 500 milligrams the day after that, 500 milligrams over an 8-hour period the day after that. If that doesn't work, you stop and you abort. So that's basically the burst ketamine. So basically, if you kind of think of it, you give a short course infusion over a couple days, see if their pain gets better. If it does, great. If not, you increase it a little bit. If that doesn't work, increase the next day. And then basically you kind of go day 5. If you don't get a response after 5 days, probably not going to work. The second method, this is actually developed by Ed Fitzgibbon. Hopefully he's not on the chat right now. He probably is. So Ed actually is here in Ottawa. So this is a paper that he wrote and a protocol that he developed. So this is basically a subcutaneous continuous infusion that you can do. So basically you have a target dose of usually about 100 milligrams, anywhere between 50 to 100 milligrams that you would infuse over a 24-hour period. So basically you kind of start low, go slow, and then you kind of go up. And then basically you just kind of slowly increase to desired effect. So basically you want to get their pain under control or a decrease in their pain. The big thing to take into consideration with this, though, is that as you're going on, you want to decrease whatever their opioid is, because you're going to get some opioid sparing. So basically, as you continue with the continuous infusion, you decrease their opioid. And you want to make sure, again, that you want to have Haldol or a benzo that's there available kind of regularly to keep them nice and calm. Okay, so those are the two kind of protocols. Then what? So really it kind of depends on your setting, where you are, and what your protocol is, either at your hospital, home care program, or hospice can support. So I know here in the Champlain region, typically we can't initiate ketamine or anything like that in the community. That'd be something that would be reserved for being in, like, say, a palliative care unit or a hospice in some cases. If the patient, though, however, is stable, so if we've figured out, like, say, if they're on a continuous infusion, they're at a nice stable dose, we don't have to titrate it. I have had it that I've been able to have people at home on a continuous ketamine infusion. If it's showing to have promise, it's keeping their pain in check and they're not having any psychomimetic effects. And then they basically are monitored the same way as they would with a CADD with a regular opioid. Also kind of depends on the patient. So really it depends on what their prognosis and what their goals of care are. So sometimes, say for the burst method, what you can do is you can do the burst method, see if they have some improvement with it. If that's great, if it works, that's great. They can head home or wherever it is that they want to go. They can kind of come back in again in a couple months or so to continue it. Really, sometimes in some cases, say for like the continuous infusion method, we'll continue it right until time of end of life. So if it's providing benefit, we would just kind of continue. So the bottom line is that retrospective and observational studies are kind of show that there's promise for refractory cancer pain. Thing you got to take into consideration is that randomized control trials is actually pretty limited. But really, at the end of the day, ketamine, it's got multiple mechanisms of benefit. NMDA for that neuropathic pain can help reduce central sensitization and opioid tolerance, and it's a good kind of next step to do after you've already kind of exhausted what opioids you can use. So let's go back to our gentleman, Mr. BK. So he's our gentleman with metastatic colorectal cancer, extensive pelvic and perineal metastases. He's got that super burning pain that's there. He's on gabapentin, duloxetine. He's on a hydromorphone CADD that's infusing, still having tons of pain. So what we do for this, we consider ketamine because it's got that NMDA receptor activity, so good for neuropathic pain. Also is getting a little bit toxic, so it can help with the toxicity. Also, he's on high doses of opioids, so it can help reduce the amount of opioid that we need. So for him, what we would do is kind of the continuous infusion method, which would be at 5 milligrams per hour subcut, so which is about 0.1 milligrams per kilogram per hour. Big things we're going to monitor for is dissociation, hypertension, vivid dreams, and then we're going to reassess his pain and function after 24 to 48 hours or so. So the outcome, and this is pretty common, usually what I see whenever I start people on ketamine infusions particularly, their pain gets improved. It goes from an 8 to a 10 and a 3 out of 10. I'm not going to say it's going to happen with everybody, but not uncommon. Reduces the hydromorphone rate by 30%, and he's more alert and has better affect, so feeling a little bit happier. So big takeaways from this is that ketamine can be ineffective for refractory neuropathic cancer pain. Start low, titrate slow. I wouldn't expect people to be doing this just off by their own. Always ask for help. That's okay. There's palliative care specialists around that are more than willing to help out. And with us, with the regional palliative consultation team, if you have any questions, feel free to reach out. Good. Any questions? Useful? Not useful?
I would suggest, Nick, we keep on keeping on, and then if there's
sure.
other things that come up.
Yeah. Okay, we got 15 minutes. Yeah, the next part's pretty quick. So I'll answer the questions then afterward. So last one that was going to talk about just nerve blocks and palliative care. So what are nerve blocks? So basically image-guided injections, local anesthetic with corticosteroid plus minus neurolytic agents. Basically what you're doing is you're trying to target somatic, visceral, or sympathetic nerves supplying painful region. So basically what you're trying to do is you're trying to target specifically the localized area that's innervated while reducing the overall systemic opioid burden. That's usually typically local refractory to opioids, despite that. So how do they do it? So typically usually this is something that's not going to be done by a lot of palliative care specialists. Typically it's going to be like an interventional anesthesiologist that's going to perform this procedure, sometimes interventional radiology. Really kind of have to reach out to who's available to you in your context. So typically kind of look for the target nerve or plexus using surface landmarks. They prep the skin with an anesthetic, apply it to the entry site. Then they basically, it's pretty simple. They put a specialized needle in, they advance it, they figure out if they're in the spot by giving a test dose. If it's having effect, they're in the right spot. And then basically they monitor the patient afterward briefly for any kind of for pain relief and if they have any complications. So the indications for kind of nerve blocks or any kind of more interventional techniques, usually it's neuropathic pain. It's not responsive to medications. Visceral pain, things like pancreatic pain or abdominal pain, somatic pain from bone or soft tissue tumors, and when side effects limit systemic treatments. Another common kind of way for blocks are neurolytic techniques. So basically, you only kind of use this in patients that the prognosis is limited and their pain is pretty severe. So instead of using things like corticosteroid or things like analgesics, what you would use is alcohol or phenol. And then basically you're intentionally trying to interrupt those pain pathways. So you're trying to kill the nerve, quote unquote. Usually we use this for things like visceral cancerous pain. So things like celiac plexus block. So that's a pretty common one for people with pancreatic pain that's got the really bad epigastric pain that's always kind of ripping through to the back. Usually can provide kind of weeks to months of relief. The big thing though is that you need an experienced interventionalist to be able to do it. So being able to chat with your local anesthesia team, they would be able to find where. So the most common blocks that we kind of see, like I previously mentioned, is the celiac plexus block. So it's usually for upper abdominal cancer pain. The superior hypogastric block, which is more so for pelvic pain. You can also have peripheral nerve blocks. So really that kind of is dependent on where the localized tumor invasion is. So very common ones that I've seen are typically more so like breast cancers that have like tumor that's or either breast or lung cancers that have tumor invading kind of into the plexus up in the arm. We can do blocks, local blocks for that. And the big thing that you see from it is to get improved comfort, reduced opioids, and better function. That's it. Blocks are pretty quick and easy. If they have pain, stick a needle in it, numb it, and then go from there.
That easy, Nick. I, okay.
Yeah, no, that's good. So
quick,
yes.
so I actually have a quick question just about the block. So you say, you need interventional radiology or an anesthesia. Like, how would you access that as a clinician? And I'm going to give Champlain as an example because I know that's your kind of lived reality.
For sure. Yeah, so the most common way, so I actually did this morning, so it's a good question. So the easiest way to be able to do it would probably be to contact anesthesia first. So you can just call anesthesia on call. A lot of anesthesiologists have training, and these are things that they do typically for things like in the OR and stuff like that. And they're just kind of adapting it more so in a palliative context. So for us in the Champlain region, typically like if they're associated with the TOH, which is the Ottawa Hospital, the general, easiest way is just kind of contact anesthesia on call, and then they'd be able to help.
Okay. There was a question about dissociation and ketamine infusions. And I'm not 100% sure. It says eye prophylaxis preferred.
I'm assuming is prophylaxis preferred. Yeah, so if you're worried about dissociation or like the psychomimetic effects with ketamine and infusions, you certainly can. So that's in a lot of the protocols. More commonly, like what I'll do is like I'll give a little bit of Ativan regularly, like low dose, 0.5 milligrams. You can give it kind of like TID while they're on the infusion. And that's usually pretty good. Again, you kind of want to start low and go slow because you want to kind of titrate it, and you kind of want to get to the point where their pain's under control, but they're kind of getting that, 2 special coffees in the morning kind of feeling. You don't want to get too much past that, if that makes sense.
Yes. Somebody also said, though, some patients might want that feeling of dissociation. Like that might be a pleasant thing for them, I guess.
Yeah, it can be too. Yeah, and that kind of is going more into the kind of the depressive and kind of mood aspect side of things. I'm kind of focusing more on the pain part of it, but that could be. So again, you just have to be careful. Again, make sure they're in a good spot, and then kind of go from there. Make sure they're in a safe environment.
There's been a little bit of some other comments about just kind of goals of care with ketamine in relation
Yeah.
to, and I think what I heard was it's more focused on pain versus sedation with
Yeah, so we're
ketamine.
using, yep. Yeah, so we're not using it as a sedative. So it can be used as a sedative if you wanted to. But the purposes of this talk was more so for the pain. So we're using it at doses that are lower to try to get the analgesic effect. So make sure that the pain's better, not necessarily trying to sedate them. That's a whole other kind of topic for sedation and kind of what the goals are in those particular instances if they're having refractory symptoms. So
There's a really quite broad question, but I think, in relation to the interventions that you've described in the context of home care and, trying to support somebody to die at home,
Yep.
like comments about, if you had to look at everything, what would you recommend or?
For sure, yeah. So I would say if we're trying to support somebody to be at home, the things I would kind of highlight, the things that are probably the most feasible things to do. We can definitely use methadone at home. We can definitely use CADD pumps at home. We use them quite frequently. Really, it's like if we were using things like ketamine, that wouldn't be something that I would kind of initiate or start at home. That'd be something that would be probably done in an inpatient setting first. And if they were stabilized, then there could be discussions with trying to support them at home. I've had patients that have gone home on ketamine infusions, like I said previously. And then, really it kind of is dependent because obviously there's always a lot of factors that kind of go into home environments and things like that. At the end of the day, I think I always kind of mention is making sure that people are safe, they're well supported, and supporting in that sense. And then for blocks, like that's not something you're going to be able to do at home. That would probably have to be in a hospital setting.
And the patient would have to be well enough to be
get to hospital,
transferred.
Yeah.
And then if they can't get up and get in a car that's non-urgent transportation and the costs associated with that potentially.
Yeah, exactly. Great point.
Speaking of costs, somebody asked about the costs of ketamine versus methadone.
Yeah, that's a great question. So I guess it depends. Cost to who? Cost to the system or cost to the patient? It's going to be covered. So if you do the PCFA or the Palliative Care Facilitated Access, it'd be free for the patient. It'd be actually covered by the Ontario government. Also, in and of itself, methadone is actually a very cheap medication as well. So I would probably say that methadone of the two is probably cheaper because ketamine typically you have to get it in solution. It's actually pretty hard to get a hold of, especially if you're in a community setting. That's something that usually has to be special ordered or made up.
Can you use ketamine and methadone at the same time?
Yep, you can. Again, the big thing that you just have to be cautious with, this is something I would probably hope that you would have like a palliative care specialist that'd be involved with, because they're two a little bit more advanced techniques. But I have 3 or 4 patients right now that are on ketamine and methadone. And really the reason why I'm using the ketamine is to kind of rapidly titrate people. The methadone that's there as well, that's kind of the more longer acting once I get them stable, and then I'm going to come down off the ketamine. So you can definitely use them together. You just have to, again, be cautious. Same as I mentioned before, make sure you're reducing your opioid if you're initiating the ketamine because their requirements are going to be less because it's opioid sparing.
Right. The only other thing, it was a bit of an earlier on with the ketamine. Somebody just mentioned about, the use of ketamine with pathological fractures as well, how it could be helpful.
Yeah, for sure. Definitely use it for pathological fractures. I also find that that and fentanyl is another pretty good one to use in a CADD pump. because the reason with fentanyl, it's fast on, fast off. So pretty good.
Somebody's written allergies question mark, anaphylaxis question mark. I don't know. Is there a higher incidence of sensitivity to any of these drugs, or have you seen that where?
No, I've never seen it. I couldn't call it. Like, could someone potentially be allergic to it? Probably. I guess you wouldn't know until you tried. So you can't, again, you treat it the same way as you're starting any other medication, right? Low and slow, and hopefully you're in an area that's got access to an EpiPen.
If you had severe incidental pain, would your choice be fentanyl or ketamine?
Yeah.
All things considered.
Yeah, all things considered. I'd probably have fentanyl because it's easier access. You can get to it quicker, faster on, faster off again. I'd probably pick fentanyl over ketamine, and people are just more comfortable with fentanyl too. So
you guys got to pay attention better to your writing because I'm reading. I'm going, what does that mean? If you wanted the world to know you were an expert in a medication/interventions in PAL, what would be your favorite pick? I guess it's your favorite medication.
My medication, I love methadone. I don't know if that's what you're asking.
Do you have a
like
T-shirt with that, or
yeah, I don't know. I guess maybe that's the question.
Start to market that.
Yeah, the big thing, methadone. It's a great medication. It's not as scary as it sounds. It has nothing to do with addiction when we're using it in a palliative care setting. And I think it's really something that I think we should be using a lot more of because it provides great benefit for patients and really gives them good quality of life.
Rena has a really specific question, but I guess the first one is more generic. In a pain crisis, can you do a test dose? Or would you do a test dose, or would you just give a therapeutic dose? Or
yeah, it's a good question. So if someone was in a pain crisis, again, I'd probably be looking at other things before ketamine. That being said, so I'd probably be trying to exhaust other things. Like if I'd probably do a test dose, and I'd probably do stacking of whatever opioid they're on. So, I'd probably give them fentanyl first again, because that's fast on. You don't have to worry about it. It's pretty well controlled. You kind of know what your doses would be first. You can actually, I did this week. I had a patient that was in a pain crisis. It was already on a fentanyl. So you can give test doses. Really, it kind of depends what they are. So for me, usually what I would kind of say is maybe a 5 milligram, which is very low, just to kind of see if they have a response, and then you can kind of up-titrate it as that. But I wouldn't be relying on the ketamine to be the number one thing. I'd be using things like opioids that I can kind of rapidly titrate and go up
on. Okay, there's actually one more here. And so the scenario is a patient who's in hospice, who's on methadone, but they're not able to swallow anymore.
Mm-hmm.
Would replacing the methadone with ketamine be something you would do?
Yeah, that's something that we kind of commonly would do. So again, the nice thing with the methadone is this guy has such a long half-life that you got kind of time, right? So again, depending on, I'm assuming if they're losing their PO route, their prognosis is probably fairly short. So you don't have to stress out that you got to get right on top of adding something on to replace that right away. If you have the option and ketamine is available, it's something you can start at a low kind of infusion, the same as what the subcutaneous infusion protocol would be from Dr. Fitzgibbon. So that would be a potential. But again, you don't have to worry because the half-life is there and it'll be around for, almost a week. So you should be okay.
And you talked about methadone being available only in oral form. Question is it available elsewhere in other routes?
Yeah, so in the States, they can actually give it IV. Or if anyone is a vet or knows of vets, you'll actually see they use methadone a lot in veterinary medicine, and they'll give it IV. Unfortunately, it's not available in Canada, so we don't have access to that here. I couldn't say exactly why.
Compounded for rectal use?
Methadone, yeah, you can. Yep. So if need be, if they're losing PO route, I actually have a couple patients that I do that for right now. So you can actually request at pharmacies to make suppositories, and they can give that if there was a real worry that you wanted to continue to get the methadone and they weren't able to take PO.
Great. Well,
Yeah.
we're at time. So on behalf of Carl and the rest of our team, Nick, we want to thank you so very much. So yeah, Nick has popped up a couple of resources there. So in the chat, I did put the methadone for pain link on the learning platform at Canadian Virtual Hospice. I put the link to the RPCT, but there's also a phone number there and in the link shared. And then, yeah, that fast facts. So these slides will be made available to folks and after the presentation and any of the resources that Nick shared, you'll be able to grab them there as well. So again, thanks to everybody who joined us, and again, thanks to Nick. If I really think I'd like you to provide care to me if I ever needed it, and it's not just
Thank you.
because I'd like to try ketamine sometime. It's kind of one of the only things I haven't experienced, I think.
I think it was a huge compliment. Thank you, Val. I appreciate that. Thank you, everyone, for spending your Thursday night with me. I appreciate it.